I'm going to try to fly through the first part of the talk, which is about pathology and pathophysiology and who should be screened for CTEPH, and focus most of my time on diagnosis, which can be really tough, and also on management strategies. And before I get too far into the weeds here, I want to say thank you to Gustavo for letting me take slides from his 200-plus slide deck that he presents about CTEPH all over the world with. So those are the topics for discussion. So fundamentally, CTEPH is pulmonary hypertension that occurs as a result from single or recurrent pulmonary emboli. And as a result of this non-resolving thrombus, patients ultimately can develop elevations in pulmonary vascular resistance, and if the disease goes on for long enough, microvascular changes to the smaller blood vessels in the lungs that almost, when patients are at end stage of this disease, they almost phenotypically behave more like they've got PAH rather than CTEPH. So what I want to try to illustrate is how these two patients are different. And I want to kind of illustrate that through the slides coming up about the pathology and pathophysiology. So on the left here, we have a patient of mine who had an acute submassive saddle pulmonary embolism. He got 6 months of anticoagulation, everything dissolved. He's feeling fine, doesn't want to come back to pulmonary clinic, doesn't need to, and is doing quite well after a quite severe event 6 months prior. On the right, we have another one of my patients who had recurrent pulmonary emboli, and with the red arrows you can see there are some changes that are consistent with chronic thromboembolic disease in the right interlobar artery. She had severe pulmonary hypertension, 36 years old, needed to go for open heart surgery to get cured of this. So very different patients, both of which have obstruction of their pulmonary arteries. And so there's a lot of thoughts and theories and hypotheses about why an acute PE becomes a chronic PE. It's kind of outside the boundaries of this discussion today to go into it in detail, but essentially there's probably multiple factors that play a role here. Abnormal remodeling of the emboli, impaired angiogenesis, abnormal inflammatory responses, impaired fibrinolysis, all of which results in either a patient resolving their abnormalities in perfusion or having persistent defects that ultimately can result in CTEPH. From a 10,000-foot view, what is actually going on inside the lungs is sort of a tale of two different lung sections. So on the one hand, this is a picture of an animal model of CTEPH actually. So on the one hand, at the bottom here, this is a section of lung that's been occluded. The right lower lobe artery has been occluded. And you can see there's an absence of perfusion here. And when you look at what's going on at a cellular level, there's what we describe as post-obstructive vasculopathy changes happening. Up here, where there's similar, in theory, there's normal perfusion going on up here, the lung is actually suffering in some cases from having more cardiac output being directed towards those areas of lung. And so this area of lung can actually get changes that are described as overflow-induced vasculopathies. So down here in the post-obstructive vasculopathy area of the lung, you can see in the microvasculature, you can even see changes that are similar to IPAH. You can see intimal fibrosis, medial thickening. You could actually see lesions that appear similar to plexiform lesions like we see with IPAH. And then up here in the area of lung that's dealing with overflow-induced vasculopathy, sometimes you see changes that are similar to what we see with end-stage HFpEF or with PVOD. You see pulmonary venule and vein intimal fibrosis and remodeling. So it's really a tale of two different vascular compartments going on in a patient with advanced CTEPH. And I like to think of this when I think about the size of the pulmonary arteries that are involved in any given CTEPH patient and how that correlates with the pathology. So I really like this illustration from this review article where essentially, the pulmonary arteries can be involved from the main pulmonary arteries down to the lobar, segmental, subsegmental arteries. That's as much as you can probably see on the imaging techniques that we obtain. So I think of that as kind of macrovascular disease, meaning I can actually see it with my eyes. Most of the alterations boil down to changes in or non-resolution of these fibrotic clots or scars that you see in these blood vessels. And then at a microvascular level, as I mentioned, the microscopic less than 1 millimeter pulmonary arterioles and arteries can get involved, and you can see changes like that are pictured here: medial thickening, intimal fibrosis, plexiform lesions. So that's all that I'm really going to say about the pathophysiology and pathology of the disease, but we'll go back to that slide when we talk about how we treat these patients, because I think fundamentally it correlates very nicely anatomically with what's going on. So really quickly, I'm going to fly through this. One of the problems with CTEPH is that pulmonary embolism is incredibly common, and CTEPH is actually very rare. So trying to tease out who should be screened for CTEPH, who needs repeat imaging studies after they've had a PE, who needs to see a pulmonary hypertension doctor versus who's going to follow up with their primary care doctor, this is really hard because there's very large volumes of patients that are dealing with this. So this is probably one of the best studies that was published to try to describe the actual incidence of CTEPH. And what they found was that for all comers with PE, it's really rare, 0.56%. Now, when you boil that down to the people who are actually going to make it into your office, meaning survivors that don't have major comorbidities that are going to limit your life expectancy, it's more like almost 3%. Your odds ratio of CTEPH is higher if it was a recurrent PE. It's higher if it was an unprovoked PE. But again, there are hundreds and thousands of patients that have PEs every year, and only a small fraction of them will develop CTEPH. And to further complicate matters, there's this phenomenon called the post-PE syndrome, which is really a whole talk in and of itself. But essentially, when a patient has a pulmonary embolus, there's a very, very diverse number of things that can occur afterwards in terms of how much symptoms are residual, how much cardiovascular limitation is residual after a pulmonary embolism, whether a patient still has residual perfusion defects on their imaging, but they may feel fine, so the radiology doesn't normalize, but the patient is doing very well. And then there's patients that actually have measurable limitations of cardiopulmonary function and chronic thrombolic changes. We call them CTED patients. And then there's those that actually have resting precapillary pH. And some of this may be a spectrum, and some of this may be overlap, but it's very challenging to tease out in the office. So from a 10,000-foot view, what I would advise in terms of who should actually be screened for CTEPH after a pulmonary embolism, and again, we could talk about this for an hour, but if a patient has radiologic features of CTEPH at the time of their index PE, which really you need a very experienced, sophisticated radiology department to pick up on some of these changes a lot of the time, but if those are present, which we'll go through later in the talk, they should be referred right away to one of us. We shouldn't wait for 3 to 6 months of anticoagulation. If a patient has persistent shortness of breath after 3 to 6 months of anticoagulation, they should receive some sort of screening, whether it's echo, biomarkers, or EKG, just to get some idea objectively of how the right ventricle is doing. Patients who have risk factors for CTEPH should be thought about really carefully. So patients who are post-splenectomy, patients with antiphospholipid antibodies, patients with, we don't see this as much anymore, but ventricular atrial shunts. These are all, conditions that put you at higher risk for non-resolving thrombus, and therefore, we should be thinking about them very carefully, especially if they're, thinking about trying to come off of anticoagulation. And then, I think what we sort of use as our major litmus is that if you have evidence of abnormal RV function or morphology at the time of the index PE, you want to make sure that RV has recovered before you stop anticoagulation and before you stop worrying about whether CTEPH is going to be a thing. So if you kind of stick with those guidelines, we won't miss these patients and we won't have significant delays in diagnosis. So diagnosing CTEPH is a very challenging but fun area of pulmonary hypertension to work in. There's a lot of reasons why it's challenging. A lot of the times there's a honeymoon period after someone recovers from their index PE. And then the patient starts to develop progressive dyspnea and exertion. Sometimes there's hemoptysis, not very often. Sometimes you can hear a bruit over the lung. Once a patient starts to develop signs of right ventricular heart dysfunction, it's not a great scenario. It probably means that things are pretty advanced and they really need to get to PH clinic. One of the things that makes it really, really hard is that in about 25% of patients, they get diagnosed with CTEPH and they've never had an acute pulmonary embolism that they know of. And so that's one of the reasons when we look at the guidelines why anyone who's coming for a PH workup gets screened for this. The other thing that's challenging is that if you just have an abnormal echo, it's not distinguishable from other forms of pulmonary hypertension. So lots of people who get pulmonary emboli also have HFpEF or also have sleep apnea or could have a little bit of precapillary pH from a number of reasons. So it definitely takes a lot of testing and a lot of careful consideration to finally get to a diagnosis here. So this is some data from the CTEPH registry in the United States, which just points out that all of these challenges in diagnosis actually tend to result in patients getting referred and ultimately diagnosed when they're in pretty late stage disease. So significant numbers of patients with New York Heart Association functional class 3 and 4 symptoms at the time of diagnosis. And when they have their right heart catheterizations, when you're going for operability assessment, pretty significant elevations in pulmonary vascular resistance. So I mentioned some of these challenges already that are at the crux of why patients can be delayed for years sometimes before we actually figure out what's going on, which is makes their treatment decision making even more challenging, and plus patients can have years of symptoms without them being addressed. So the diagnostic process in a very simplified way here is that you should suspect CTEPH in those scenarios we already talked about. If you suspect CTEPH, the next step really is to get an echo to look for RV dysfunction or suggestions of pH, and then also get a VQ scan. If those are abnormal and they confirm there's perfusion defects, then you need a CT pulmonary with pulmonary angiography or digital subtraction angiography to further characterize and phenotype where the thrombotic burden is and confirm that it's there. And then also a right heart catheterization to confirm what the current hemodynamic status is. So these are the most recent guidelines that were just published a couple of months ago by the European Respiratory Society. I'll highlight a couple of things here. The first is what I kind of already mentioned, that anybody who comes for a pulmonary hypertension workup should be screened for CTEPH because of that 30% of people who present with CTEPH with their first knowledge of having a thrombotic event at the time that they're diagnosed with PH. And then patients with those residual symptoms or risk factors that we talked about. The other thing that I'll mention in the guidelines that I just want to highlight because it's newer this year is that there's an emphasis from the European group on if somebody has abnormal perfusion but a normal echo and they're still having symptoms, that it is reasonable and a good idea to pursue more advanced physiologic testing with exercise testing. They advocate for CPETs. We actually do a lot of invasive CPETs here, which are extremely useful. And the reason for that is that you can actually, in a patient with the right hemodynamic phenotype with exercise, we actually will still offer full surgical and mechanical interventions for these patients, even if they don't have resting pH, because they can really improve quality of life, exercise tolerance, and gain a lot of symptomatic relief. So at this point, we're going to work our way further down the diagnostic pathway. Assume you have, an abnormal VQ scan. What do you do next? So quickly, this is what a normal perfusion scan looks like. The only point that I want to make about this is that a low probability VQ is not the same thing as having normal perfusion. Okay, so patients, for a number of reasons, can have abnormal ventilation on their abnormal ventilation on a VQ scan. And partially matched or partially mismatched perfusion defects, and it'll get called as low probability. That doesn't mean that they have resolved their PE. So I think that's an important thing to just consider, that just that one-liner that you get from nuclear medicine saying low probability of PE doesn't necessarily mean that you're done. So this is an abnormal VQ scan. I think most of us have seen these before, but just to kind of review, basically the patient is given radionucleotide tagged aerosolized material to breathe in, which is shown in the bottom rows here, and then they also are given a similar substance through their veins. And it's very simple. Everywhere that you're sending air in your lungs, you should also send blood. If you're not doing that, it's a mismatch. SPECT VQ is a little bit more sophisticated than the planar VQ that I just showed you, in that you can get three-dimensional images. It's a bit more sensitive for detecting perfusion defects. It's preferred in the European guidelines. And there used to be like a thought that basically CT wasn't as sensitive for detecting CTEPH, that VQ really was like the gold standard for detecting it. As techniques have gotten better, both of these techniques are really, coming closer together as screening tests for figuring out if a, patient has CTEPH or not, or suggestion of a patient has CTEPH or not. What I will mention is that VQ can be a little bit more limited if you have really proximal disease, because you may still be getting perfusion around those large proximal clots. Whereas CT starts to lose a little bit of its sensitivity and specificity when you're out in the distal segmental and subsegmental pulmonary arteries, and sometimes you need help with that. So I'm going to go through a case that kind of goes through some of the diagnostic challenges and gives you an example of how we use the different imaging modalities to help us figure out what to do. So this was a patient, I believe, of Gustavo's, 64-year-old gentleman. I'm actually starting with his right heart catheterization, in which you can see he has severe precapillary pulmonary hypertension. He had a CT scan, which was called as negative. I think there's nothing on these images that would suggest that there's certainly a large acute pulmonary embolism. One of the things I would just point out is there's kind of a paucity of blood vessels in the periphery of his lungs, which is a little bit of a tell, but not a slam dunk by any way, shape, or means. And then when you scrutinize a little bit closer, you can see, maybe there's like a chronic web here. That would not give you a PVR of 20 all by itself, but there's probably some abnormalities in the more distal vasculature here. So he goes for a VQ scan, and this actually becomes quite helpful. So he has pristine, normal ventilation, and on the posterior views here, you can see he's got very large mismatched perfusion defects bilaterally in the right and the left lungs. And so at this point, you've got this negative CTPE, you've got severe pulmonary hypertension, but you have a perfusion scan which is quite compelling for segmental or even lobar perfusion defects going on. So what do? You get a PEagram. So I'm actually going to line his PEagram up with, because spoiler alert, this guy went to surgery. So I'm going to line it up with what we got extracted out at surgery, but this PEagram is quite abnormal. You can see abrupt truncation of one of the blood vessels here, as well as distal tapering and narrowing in the right lower lobe here. There's kind of an absence of a blush down here in the left, or the left lower lobe. Sorry, excuse me, this is the left side. And when we went to surgery and he had extraction done, you can see he had some very significant endothelial stripping that occurred proximally, and then a lot of this distal segmental disease that was removed from multiple different blood vessels. On the right side, it was a similar story. So you're kind of missing the right middle lobe, the right lower lobe vessels are missing a couple blood vessels too with abrupt truncations. You can see here there's kind of almost like a cutoff and an absence of flow distal. And again, when he went to surgery, not hulking clots removed, but these sort of smaller fibrotic abnormal endothelium stripping out of the lining of the blood vessels, but impacting multiple sections of lung. And post-op, his PVR is now close to 3, so it's normal, okay? This is obviously an extreme case, but I think that the bottom line is that if you have abnormal perfusion on your VQ scan and the CT is negative, you probably need to do a little bit more work to be confident that you're not missing this, because there's such an opportunity to cure these patients potentially. So there's a variety of abnormalities that can result in abnormal radiology. So patients can have frank thrombus, they can have webs, they can have recannulization of the chronic thrombi, stenosis. And actually what ends up happening on CT when you see some of these things is sometimes you're actually looking for the absence of blood vessels as opposed to the presence of these findings. So here you can see a web in one of the segmental arteries. Up here you can see retraction of the blood vessel and almost like atrophy. This is lining thrombus, and the yellow arrow shows some calcification within it. And then here, actually, you can see stenosis with post-stenotic dilation. The other things that sometimes we see that can throw us off a little bit are, you can see mosaic attenuation on the CT scan, and sometimes it's so profound that you actually wonder if a patient has underlying parenchymal lung disease. The clue, though, is it's kind of a mirror image of your VQ. So you end up having more heavily perfused areas appearing like they have ground glass opacities almost, and it's because of that overflow phenomenon that's going on. You can also see bronchial artery collaterals, which is a really nice clue. Often we end up getting pulmonary angiograms. You know, a high-quality PA-gram is a little bit of a lost art in the world, but generally you need 2 views 90 degrees apart to open up the various lobes of the lung. And here it is on the left as well. Some of the signs you can see on PA-gram that may be harder to appreciate on CT, because again, with CT, you're kind of looking for the absence of blood vessels, are this is stenosis, abrupt cutoffs and sort of beaking of these blood vessels. This is almost like a little stump where there should be a blood vessel here. This is all signs of, you know, likely there's some sort of proximal occlusion here that you can strip out with surgery and the patients are going to get better. Pouch-like defects and bands are other things that you can see on a PA-gram and appreciate but more effectively. And then, you know, some more findings that you can see on a PA-gram, sort of these complex webs and meshes. These are usually more amenable to BPA, abrupt narrowing or tapering of the pulmonary arteries. These are all findings on PA-gram that can be very helpful when we're mapping out a treatment plan. So I'm just going to talk for 1 second about dual energy CT scan because this has become more widely available and a lot of people have questions about it. So a dual energy CT, essentially what it does is it picks up the iodine that is intravascular, so it tells you about the characteristics of the inside of the pulmonary arteries. And then it also does calculates the amount of iodine that's going out into the parenchyma of the lungs. And so what you end up with, you can kind of see up here, is that you get a good idea of what's going on intravascularly, and then you also end up with these perfusion defects when you look at the dual energy CT scan. So the thing that's nice about it is actually it's much more sensitive for picking up vascular abnormalities in the subsegmental pulmonary arteries, which was where CT kind of previously was dropping off in sensitivity and specificity. And then, you know, in the research world, people are still teasing out, there actually probably are some ways that you can differentiate chronic PEs from acute PEs with dual energy CT scan, which, you know, will hopefully be helpful. People sometimes ask me, if you get one of these, do you still need a VQ? Technically, if you're just doing the perfusion side of the VQ scan, it's probably going to give you similar information, but the nice thing about the ventilation side is it actually tells you if that's viable lung that's getting ventilated and getting air. Okay, I actually don't know where we are with time, I'm sorry. I'm okay, 5 minutes, okay. So that's everything I have to say about diagnosis. I'm gonna try to talk a little bit quickly about some highlights of management because there's a lot we do for these people. So again, here's the treatment guidelines, and the key thing here is first and foremost an operability assessment. So CTEPH is a surgical disease, first and foremost, and it needs to be sort of that's the default option for patients until an advanced CTEPH center says it's not a good idea. Operability assessment is where Gustavo and I spend a lot of our time. You need high quality imaging, you need an excellent group of surgeons, you need hemodynamics that fit the profile, you need patients that don't have comorbidities that's gonna make it higher risk, and center experience is extremely important when you're taking into account operability assessment. This particular patient has pulmonary hypertension that's way out of proportion to what you would expect from their thrombotic burden. So what you can see here is that they have a PVR of 1500, and a lot of sort of distal pruning and tapering, which sometimes you can see with CTEPH, but you can also see with IPAH, and a lot of subpleural hypoperfusion, suggesting there's a significant microvascular disease component. This patient is a slam dunk surgical patient if they don't have comorbidities. Again, lots of proximal disease here with absence of blood flow further along, PVR that's in proportion to the areas of lung that aren't getting blood flow, should definitely go to surgery, should not wait to do anything else. Things we like to see in operability assessment, we like to see our pulmonary angiogram and our VQ correlate so that we know that we're going to be removing clots from areas of lung that will hopefully reperfuse. If we see that if there's a totally normal VQ scan, we don't like that at all because those patients were not as confident that they're going to feel better from a huge surgery. Lower lobe disease has a better prognosis in terms of improvement in patients, so we love to see that. And then in terms of surviving the surgery, reduction of PVR is key. So this is data from UCSD, and essentially, if their immediate post-op PVR was less than 500, their 30-day mortality was very, very good. If their post-op PVR was greater than 500, they had this is older data, but almost a 10% in-hospital mortality from the operation itself. And then it actually is a prediction of long-term survival as well, this immediate post-operative PVR. So just a 1,000-foot view of why that's important. So it's a big surgery. Not everybody should get it necessarily, depending on their comorbidities. It's a median sternotomy, it's an endarterectomy, you have to go on cardiopulmonary bypass, you have to be able to tolerate deep hypothermia and all the medications that go with that. It's, you know, I tell my patients it's gonna be a big surgery, a big recovery, but a big reward potentially if we go through with this. This is the UCSD surgical classification. You're considered a excellent CTEPH center if you can get to level 3 and 4 disease. So post-operatively, there's a lot of things that can happen, and some of you guys may encounter this as we're taking care of our patients in the hospital. Everybody needs diuresis. They need to go back on their anticoagulation. If people have persistent pH, that is something that sometimes we address even in the hospital, sometimes we don't. I'll give you a little bit more data about that in a second. And then there's complications like Steele phenomenon and reperfusion injury, which frequently can cause very high levels of hypoxia immediately post-op. In the interest of time, I'm going to skip over talking about reperfusion and Steele. So this is our Cleveland Clinic PTE experience. Basically, the multidisciplinary team got formed at around 2011, and since then the program has exploded in terms of volume. We've done 311 PTEs in about the past 12 years. Our mortality is excellent. This is, for every CTEPH patient that we actually take to surgery, we probably are reviewing, 10 to 15 patients that end up not going to surgery or getting a different treatment modality. Improvement in PVR is key, as I mentioned, and we're seeing that here in Cleveland Clinic, that we're getting sustained results in improvement in PVR in our operative population. And the patients get better in terms of their walk distance and functional class as well, which is your criteria for improvement. Long-term, patients that are operated on survive much longer than patients that are either inoperable or operable but have comorbidities that would keep them from going to surgery. So again, surgical consideration and operability assessment is key for these people. Residual pulmonary hypertension after PTE is something that's a little bit of a moving target in terms of defining it. It happens in about 50% of patients if we use the mean pulmonary pressure of 25 as a cutoff. It has an impact on survival when your mean pulmonary pressure is greater than 38, and typically treatment is getting initiated at around 30. And this is in right heart catheterizations measured about 3 to 6 months after surgery. It's just the PVR data that's the same. So from a surgical management standpoint, these are the highlights from what I just talked about. I don't think I'm going to have time to go into too much about BPA at this point, but I'll just mention for patients that are not operable, there's basically a combination of medical therapy with pulmonary vasodilators and balloon angioplasty is what we can offer them. And I'll just skip ahead to my last slide, which I think highlights the best way to put that into practice. So BPA was started about 20 years ago, but really started picking up here in the United States in the last decade. The Japanese get really good long-term, have reported really good long-term hemodynamic benefits from it, and we're starting to see that in other registries as well. Like I said, I'll unfortunately need to skip through these. So just to go over, this is one of the latest trials that came out in the CTEPH world, so I wanted to review it really quickly because I wanted to give you the latest and greatest. So the RACE trial just got published. And essentially what this trial was looking at was, should a patient go for medical therapy with riociguat or balloon angioplasty, and which one should you do first? And what they found was that when patients went for BPA first, they had more dramatic improvements in PVR and functional status. However, after all of the Rio-Sigwat patients that wanted to, or who were still symptomatic, crossed over, so they got Rio first and they crossed over and got all the BPA they needed, they actually had similar hemodynamics and similar functional class at 52 weeks. And what they actually found was that the safety events were so much lower in the patients that got Rio-Sigwat first and then got BPA after that. And it's probably because there's fewer safety events when your mean pulmonary pressures are lower. So Rio was, hopefully doing that. So at Cleveland Clinic, we did our first BPA in 2016. Since then, this is a little bit of older data. We've also been really busy from that standpoint. Our complication rate is about 6%, and we've had no deaths. So I want to end with this slide, which has a little bit more detail in here. But essentially, CTEPH, once it's diagnosed, the treatment is actually pretty simple. You offer mechanical solutions for the macrovascular disease, and whether that's with surgical extraction or with balloon angioplasty, it's very patient-specific and centered. And then medical therapy if there's a significant component of microvascular disease. And that way you can target all of the blood vessels that are potentially being impacted and help these patients do better overall. And that's all that I have for right now.
Thank you so much.